Welcome to this week's installment of Stat Plus Conversations, a weekly video chat series exclusively for Stat Plus subscribers. Thanks for joining us. I'm Casey Ross, National Technology Correspondent here at Stat. And in just a few moments, I'll be joined by Katie Palmer, Stat Health Tech Correspondent. But first, a few quick housekeeping items. At the bottom of your screen, you should see a few icons. Use the chat feature to chat amongst yourselves or send a message directly to the Stat team. Please note that we will not be taking questions directly from the chat. If you do have a question, and we hope you do, please use the Q&A feature to type it, and we will try to answer it live. You'll also be able to see the questions that other attendees have asked and upvote the questions you'd most like to have answered. We'll be taking your questions throughout our conversation, so start asking them now. No need to hold off until the end. Before we get started, you may have noticed that Stat Plus Conversations are being sponsored by Premier for the month of August. And with that, I'd like to first welcome Lee Anderson, President of Performance Service at Premier, for a brief recorded introduction.
Hello, everyone. I'm Lee Anderson, President of Performance Services at Premier. Thank you for tuning into Stat Plus Conversations and the HIMSS21 wrap-up discussion. From the Premier lens, HIMSS this year was the place to be for big concepts. As in the past, AI was a big focus. AI is at an inflection point, no longer a theory. As with any technology innovation, we often see 2 steps forward and 1 step back. We heard a lot about that in the press. AI is now the month of July in a teaching hospital, right? It is the first month of a new resident eager to apply their new knowledge and skills. And it's part of a learning curve, right? Premier believes that the future of healthcare is found in the minds of innovators, of those who are bold enough to craft new possibilities and take the first step, the bold steps to deliver. We've taken the first step with a real world practical application of AI at the point of care, improving the way care is delivered as well as patient outcomes. We're now taking the next step, right? Last week, Premier was thrilled to announce that we are branding our data and AI-enabled technology and services platform. So versus a point solution, it's a platform play, and we call it Pink AI. Our artificial intelligence, machine learning solutions, and other technologies across our portfolio. So if you think about, procure to pay and Remitra, if you think about clinical decision support and Stanson, Pink AI is already delivering intelligent healthcare at the point of order, right? And helping providers recover revenue. For example, with reading text in the EMR for HCC scoring. So our ability to enable coding accuracies, deliver evidence-based guidance in the EHR workflow, and help providers deliver better care. Why Pink AI? We believe we've got an unparalleled data set. We believe that we have the amazing history of delivering this data set and innovation inside of healthcare. We believe that these data analytics, clinical intelligence capabilities at the point of order, combined with driving value, differentiation, provider-led, and advancing that innovation solution collaboratively with other stakeholders in healthcare, life sciences, carriers, employers, uniquely positions us. Ultimately, we're focused on putting care back into healthcare, and we believe by delivering Pink AI and other enhanced technologies, including predictive analytics, clinical decision support, surveillance, and even our margin transformation improvement consulting organization, which really delivers sort of performance-based value for providers. We think that Pink AI will enable that platform while effectively helping hospitals come out of this COVID-19 solution and improve their margins. We think that adjacent markets will also benefit. We believe that automating administrative tasks, right, whether it be documentation, coding support to support front-end and back-end prior authorization, we believe we're uniquely positioned to make that happen. We believe AI is uniquely positioned to make that happen. The real-world evidence and clinical trials innovation, whether it be selecting a site or selecting a patient to accelerate research for medical devices, diagnostics, and pharmaceutical companies, connecting high-value provider networks to employer-sponsored health plans, and to automate invoicing, procure-to-pay between providers and suppliers are all areas that we're going to tackle with this platform. Just want to thank everyone for giving me a few minutes, and hope everyone has safe travels home.
Thank you, Lee. Now I'd like to introduce my colleague to discuss last week at HIMSS. Please welcome Katie Palmer, Stat Health Tech correspondent. Thanks for joining me today, Katie.
Hi, Casey. Thanks. I am excited to dive into the wild week that we had, the two very different wild weeks we had at HIMSS.
Yes, it was quite a week. I mean, in the run up to the conference this year was really challenging because you saw that the cases of COVID in Las Vegas were spiking. I mean, the timing was really unfortunate. Right in those weeks, you saw, the waves start to go like this of cases, and really a third wave became, apparent. And so all these organizations were having conversations about whether to attend, how to attend, whether to scale back. I mean, I don't know how your experience was leading up to it, but the days before it, nobody would sort of answer my questions about, are you going to be there? Are you not? How are you going to be there? Are you going to be in person? Are you going to be exhibiting? What's going to be happening? It was really hard to
felt very much like the very beginning of the pandemic, all of that uncertainty and just the inability to really clearly assess risk levels. So what we decided is you went in person, I stayed digital. HIMSS did have a vaccination requirement for everybody who was there in person in Las Vegas. And then as of the week beforehand, when the CDC changed its mask guidance, Clark County, Las Vegas also instituted their mask mandate. So it seems like you felt like everything was pretty safe there.
Yeah, I mean, I did not feel unsafe at any point during the conference. I feel like the precautions that were taken were very reasonable. And also the conference was very spread out this year. I mean, not only was the attendance sparser, but also you had great distance between, the venues, to the point where I think I logged 40 some odd thousand steps just kind of going back and forth between things. So, I mean, I will say that there were some moments where everybody who's ever been to HIMSS or any conference really realizes that at 5 o'clock, you kind of kick into the after hours, like, events in bars and restaurants. And there were times where I walked by, restaurants or bars with, people with their HIMSS badges on, standing cheek by jowl with drinks in hand and no mask on. So that sort of it was a little disquieting. I preferred to eat dinner alone, as I always do as an introvert. But that said, I also really enjoyed being at HIMSS this week. It was just really nice to get out and to be part of the conversation in person, because there is so much important stuff to talk about.
Yeah, and there was plenty of interesting stuff on the digital track as well, though, as I'm sure many of us have experienced this year, it's still a big challenge to pull off an engaging digital conference. So kudos to HIMSS for pulling off a fully digital track, which I believe is the first time that the conference has had anything like that. But it was definitely a very different experience, having pre-recorded panels, different types of moderation, and different sort of scales of insight into digital health technology. In person and in the digital track. So we'll talk through some of that.
Yeah, and let's talk a little bit about, just before we get into all the topics we want to address today, let's talk about attendance. Thursday, HIMSS officially sort of certified to the media the attendance numbers, which in person was 19,000, which was surprising to me, because if I was just guessing, I probably would have said closer to like 12 or 14 or 15. What was the digital?
I think it was in the realm of 5,000, but I wouldn't quote me on that.
Yeah, it was. Yeah, I think they said 5,000. So 24,000. For the week, which, given the circumstances, was pretty good. I mean, HIMSS had to pull something off in a very, very tough spot here. But let's dive into the topics that we wanted to talk about. What we learned at HIMSS, through the week. We wanted to talk first about sort of the uncertainty that we saw both in the digital and in-person programs over, the future of the pandemic, digital health use, the regulations. One of the things that jumped out at me during the discussions on telehealth in particular was the extent of the drop-off that has occurred within large health systems of telehealth use. Most of the organizations that I saw speak about it talked about an 85% drop-off from peak telehealth use, or telehealth use around April and May of 2020, when the pandemic was really increasing rapidly, which that's still a significant increase from them. I mean, a 15 to 20 to 25% increase in telehealth use. But it also means that change is causing a lot of them to re-examine right now, right? How do we do this? Like, how do you remake your care pathways for all these different specialties and disease states to wrap in a number of telehealth visits? How do you do that? What are the outcomes going to look like? Is that the right thing to do? What evidence do we have to back that up?
Yeah, and I think it's being really felt at every level of care. I remember one panel where a gastroenterologist was talking about just the guilt that she feels now having to have certain appointments in person that she knows would be just as well served, the patient would be just as well served if they had that over a video call, but she doesn't quite have the ability or the infrastructure to pull that off yet. So I think patients are feeling it. If you're feeling it as a patient, your providers are feeling it too. And all of the policymakers and the people at these, management levels and all of these different healthcare systems are really trying to figure out what, I guess the buzzword at HIMSS was hybrid healthcare systems. We know that there's going to be greater value in certain forms of care staying virtual, whether that means a video call or a phone call or just messaging. But you will have to have in person, and nobody's quite set up for having those two play together really well. And more importantly, I guess for some people, is how are those things going to be reimbursed? And we definitely have some temporary regulations in place that ease those paths to reimbursement for telecare, but some of those are going to expire, and there's a lot of uncertainty about how we're going to keep those systems running as reimbursement stays in flux.
Yeah, absolutely. I mean, it's amazing the extent to which, this time period mirrors in some ways, April and May and June of 2020, in the sense that we don't really know what the future of this pandemic is going to look like over the next few months in terms of the number of cases, and then how that's going to affect the regulatory decisions on, the public health emergency and all of the flexibilities that were granted during that time frame. Home hospital, telehealth use, remote patient monitoring, we heard all through the conference, this was discussed as, a moment where, the use of the word silver lining, we've heard that one a lot, right? You've written about that, but those technologies all gained significant uptake, but now there's just a ton of uncertainty about what the regulatory environment is going to look like for those going forward. So it seems like a lot of organizations are making decisions in a fog again.
Yeah, one of my favorite panels on the digital track was 3 former agency officials. A.B. Abernethy was one of them, and they just talked really broadly about what CMS, FDA are going to do going forward. Clearly what A.B. Abernethy says was, we don't unlearn. Things are going to have to go back to the way they were, at least temporarily, but the lessons are not being discarded at each of these organizations. They in particular focused on the question of real world data and how that's going to be incorporated into more regulatory decisions going forward, which has obviously it's interesting, like the pandemic sped up a lot of processes that were already in place. Like when we talk about, interoperability, information blocking rules, like these were, written into law and just happened to go into effect during the pandemic. But all of those things coinciding, I think, are really rapidly accelerating some of the change, or at least some of the desire for change.
One of my favorite conversations, one of the most interesting ones I had during the conference, switching gears to sort of COVID and misinformation, and coming up with a sort of technology strategy during the pandemic, was with Hans Kluge, who's the Europe director for the World Health Organization. And he articulated for me a strategy, basically the need for a global strategy on use of technology during the pandemic. We specifically zeroed in on misinformation because it is such a scourge right now, with that fueling vaccine hesitancy in so many realms. We talked about a system that the World Health Organization has deployed called EARS. That's the acronym for it, but it basically involves the use of artificial intelligence to surveil communities around the globe for high rates of vaccine misinformation, how misinformation is arising, how that is affecting low vaccination rates, and then crafting strategies around that to combat it. It seemed like technology is right now part of the problem in terms of the spread of misinformation, but it can also be part of the solution, to really help get us out of this. So that was a really interesting conversation, and I think really highlighted the importance of careful, thoughtful use of technology, over the next several months.
Yeah, and that was definitely the perspective of two health executives from YouTube and Facebook who spoke in a digital session on Thursday. They talked a little bit about how their platforms are, they implemented several different changes in policy throughout the year to cut down on the misinformation spreading on their platforms, millions of pieces of content removed, but mostly the policies involved in removing the misinformation were not highlighted in that conversation as much as the platform's proactive actions to promote accurate information. So they're really, trying to promote their ability to surface information about where to get a vaccine on their platforms, capitalizing on their influencer communities to get, Dr. Fauci on people's screens when they might not previously have been exposed to him. So that's definitely where these tech platforms are trying to orient our attention. But the fact is they do have a ton of information that can tell us about the dynamics of misinformation sharing and what's really driving people to the information that could lead to negative health effects. And I think we still have a lot more room to grow and understand there.
Yeah, I mean, did that read to you like a PR strategy? Like, hey, we're mounting an effective offense, but what about the defense here? Isn't the defense what wins Super Bowls?
Yeah, I think there's definitely some of that, but it's also not fair to compare really, because it seems like the problem of removing and understanding misinformation is so much greater than the problem of actively surfacing positive and accurate information. Not that either is easy, but one is definitely an order of magnitude more difficult.
Yeah.
So I'm not surprised.
Yeah, let's talk about interoperability. A lot of discussion about that during the conference. A lot of progress being made sort of on the regulatory front, if not yet the technical and sort of the on the ground thing. But I mean, I think COVID-19 really brought into sharp relief sort of the need for interoperability in the sense. I mean, you can almost think about it like 9/11. In the months leading up to that, in the sense that you had intelligence agencies with information that was not being shared about an event that that eventually unfolded with tragic consequences. And in this case, you have healthcare providers with a lot of really valuable information and yet lack the capability to share it in an effective way that could have informed the response and informed it in a more tailored way where you could really respond to some of the problems that were arising. So I think that was very clear at HIMSS that there was, okay, this is something we really need to work hard on and to pursue with a sense of urgency. I heard that in the comments that were made during sessions that were sponsored, that were hosted by the Office of the National Coordinator. There was some conversation about TEFCA, which is an acronym for Trusted Exchange Frameworks and Common Agreement. This is a regulation that's likely to come out in the first quarter of next year that would establish a sort of a universal framework for sharing basic clinical information among providers. I think it's really crucial to be able to gather all that information in one place so that it can be shared, that patients can access it, that we're not running around to all of the different silos to compile insights and crucial information. So that's something to watch, in that ONC made a point of emphasizing during HIMSS.
Yeah, and the thing that I've been trying to wrap my mind around, and I think it will be impossible for a lot of people to go forward and understand without really wrapping their minds around, is just how data standardization plays into that. We're all going to have to understand what the heck FHIR actually means, because you can't build these interoperable systems unless you have a uniform set of data elements that are transferable between different electronic healthcare records, and not just healthcare records, but claims data and public health data, and have it all speak the same language. So that's something that I heard talked about a lot in some of these sessions, and it's so wonky and it can be so difficult to wrap your mind around. But one thing in particular that people were excited about was the updating of some of those core data interoperability elements, the USCDI, which just last month were updated to include, the next version will include sexual orientation, gender identity, and a wide range of social determinants of health. So having those data elements in particular be uniform across different systems should enable us, hopefully, to gain better insights into the impacts of those kinds of variables on long-term health.
Yeah, that was discussed by ONC in relation to health information exchanges in a program they've established there, as well, which I think is especially crucial as we think about the disproportionate impacts that the pandemic has had on communities of color, to be able to understand those impacts, to have the data so that local officials can actually do something to respond to that in a proactive way, or even in a reactive way now, to sort of figure out, all right, how do we address that issue, which is a good segue into the next part of the conversation we're going to have on health equity. Before we get there, I wanted to pose a question which I think is right in your realm, Katie, that came in from an attendee, which is Tim Wing was asking, when you say this year's HIMSS is fully virtual, do you mean all sessions are available online? I know this is something that you've had some direct experiences with. He says, I only see some sessions online. Hope I'm not missing things. So
No,
is he missing?
You are not missing anything. Certainly not everything. So the vast majority of the in-person events were not available virtually. There was a totally separate digital track on HIMSS, where I assume, Casey, you had so much going on that you could have tuned into some of the digital events, but you certainly could have. And then there were a very small number of in-person events that ended up being added to the digital track at the last moment as HIMSS sort of reacted to realizing that people were dropping out and choosing not to come in person. So yeah, mostly entirely different in the two tracks.
And jump in and talk about, on the health equity front, the efforts to sort of standardize social determinants data collection and the implications that can have, and what information to collect, what the implications of collecting that information and then using it are.
Yeah, there was one interesting talk by the CEO of Blue Cross Blue Shield talking about the importance of this, but basically just how far we still have to go to standardize these data elements. When we talk about social determinants of health, it's a list of 15 or so different categories, from educational status to home security and insecurity, to job security and insecurity. So if we think about all these elements of our lives, they're extremely multifaceted, and it's really difficult to come up with a standard set of surveys that you could apply to patients. So that's something that a group called the Gravity Project from HL7, the organization that implemented the FHIR standard, is working on now. And that's going to become sort of the default way that these standardized data elements for social determinants of health are eventually, unified in all of these different health records, but there's still so much work to be done. They're just basically getting going now. And then over the next year or two, we're going to start seeing those actually enter practice in a more regular way. But it's difficult to imagine what that looks like. There are so many different uses for social determinants of health once they become more standardized and more commonly entered into these records. So one thing that we're watching out for, and was a point of interest at HIMSS, was the potential, obviously, for reducing inequity in different healthcare by understanding at a population level how these different social determinants influence care. But then we also have to watch out for ways that codifying that information in records could establish and perpetuate those inequities in different ways. So maybe that's something you can talk about in more detail.
Yeah, there was a question I wanted to wrap in here from an attendee too, which is kind of relevant to both interoperability and to this subject. How will patients be able to opt out, especially if they are not currently in a chronic condition situation or foresee needing insurance in the next few years? Will there be more laws around, health privacy surrounding sort of the sharing of information? Do you have a perspective on that? Did that come up in the conversations you saw?
Gosh, I'm not really sure about opting out. I do know, at least from one perspective, that patient privacy is a huge concern as we get more interoperability established. So especially with the data blocking rules in effect, health providers are now required to have really easy access APIs to enable patients to get access to their health data. And one hacker who co-presented or presented at DEF CON and planned to present at HIMSS but had a kerfuffle and didn't in the end, has been doing research onto some of those APIs and found that it's actually extraordinarily easy to access full patient records through some of those existing APIs. There's standardization in the data elements, but less so in many cases in the security applied to them. So that's something that the industry is going to have to be enormously careful about. That's not a direct answer to your question, Christy, but basically I'm saying your questions are very well pointed, and I hope we get some better answers soon.
Yeah, and there was a lot of discussion on this, that I saw pertaining to use of patient data in machine learning algorithms to develop those kinds of products. Should there be, a way for patients to opt out of that? And, I think there's an emerging sort of consensus that there needs to be something like that. There needs to be first greater clarity about how and when and in what circumstances patient data are being shared, how that information, is being used, and what sort of the implications and rights are of the sources of that data. And I think that there was a lot of discussion about the need to inform patients about that, and then to give them an opportunity to opt out if they wish, because I don't think that initial blanket consent that everybody signs to give care, does that give organizations carte blanche to use the data in this way. And I was hearing a lot of no's on that, and that there needs to be an awakening to the implications and how to deal with that. So it's a really important topic of discussion right now. The other issue that came up during the conference that I wanted to reference as well was cybersecurity. There was a lot of discussion around. I mean, there's been such an increase in the number of ransomware attacks. I mean, if anybody is a reader of Becker's, for instance, that they're sort of they've become the media outlet of record for every ransomware attack which occurs, and it's really disturbing to see the number of attacks, how much data is being affected by that, how many organizations are being affected. The question that was really interesting that was taken up in a panel that I saw, which involved Mike Rogers, who's the former head of the NSA and the US Cyber Command, do organizations pay? Should they pay? When you're hit by a ransomware attack. And the point that was sort of made is that the hackers right now have all of the leverage, because right now organizations are paying, and they are paying because they don't have a choice operationally. If you wake up one day to find that your servers are locked, and so are all of your patient data that you need to run your daily operations, you don't really have much of a choice, in many of those situations, but to pay. But that fact, is giving more power to the hackers to do this with impunity, and to continue to command large ransom. So should there be a regulation then, that prohibits paying of ransom? There was an argument made by the former chief security officer at Facebook that we just have to accept that short-term pain in order to get the long-term gain of removing some of the incentive for these attacks. Did you hear much conversation on this on your end, Katie?
There was a little bit less overlap on the digital side in terms of cybersecurity coverage. However, I did want to point out this is a HIMSS talk, but not a DEF CON talk, but they happen so close together that it's worth combining them in some ways. There was one presentation at DEF CON talking about cyber threats for hospital systems in particular, and the main point that those presenters left me with was ransomware is the end of the funnel. There are so many more vulnerabilities in these systems, and so much money to be made from just tapping into the system and not even getting to the point of asking for ransom for the patient records. Like if they have a steady stream of records that they can sell for $1,000 a pop, you know, if they're asking for ransom, they might have had access to your records for months, years on end beforehand. So it was just basically a huge call to action for hospital systems to get their ducks in a row right away, because ransomware is really just the end stage of the game. There probably are a lot more vulnerabilities than people are even aware of.
Mm-hmm. Yeah, and I wanted to break in with a little bit of a breaking news kind of alert question / question from an attendee, Patty Padmanabhan, who I speak to from time to time. He's a consultant in the industry, writes, "This just came through from HIMSS. We are contacting you because we have learned that 3 participants in the HIMSS21 Global Conference received positive COVID-19 test results. 1 received a positive test result in Las Vegas before returning home, and 2 received positive test results after experiencing mild symptoms upon their return home." So that's an interesting development. I know that HIMSS on the ground, from the briefings that we got, they were having like daily incident sort of reporting sessions where they would go over the events. And I don't know if this is one of the cases that was referenced in this email that Patty got, but I know that a reporter had tested positive upon landing in Las Vegas, but before coming to the conference. And so that person never did actually arrive in Las Vegas. But these are the kinds of things I think that, you know, folks are going to be watching carefully. I mean, the implications of this as people return home to their communities, you know, did this event, which was one of the first to be held in person, you know, is it going to lead to transmission?
Yeah, and you know, as we talked to people beforehand, thinking through these questions, William Hannage at Harvard Chan Public Health said basically that we know there's going to be transmission at HIMSS. This isn't a surprise. The question is just how much, and how much can we stomach? So I guess we will learn a fuller answer to that question over the next week and two. I think we left off a little while ago talking about health inequity and its extension to some of the work that you're doing in understanding the implications of all these machine learning systems, which is another major topic at HIMSS. So I wonder if we want to reorient to that.
Yeah, thank you for bringing us back on course. Yeah, I'll dive into that because, so for the first year, HIMSS had a separate forum, which was held on Monday, for specifically focused on machine learning implementation of machine learning implications, questions surrounding evidence and use, which is really a hugely important topic, and it was packed. I mean, that was one of the few events that I attended at HIMSS this year where there wasn't a room to sit. And it was a good program. I mean, you know, like everything at HIMSS this year, a few of the speakers dropped out because they couldn't attend in person, or a flight was canceled, or COVID happened, or whatever. But that said, it was really interesting and a huge part of the discussion. Usually at HIMSS, and at most health technology conferences, we're usually talking about the positive impacts of machine learning, the potential of it, right? Like the promise side of AI, where there are a lot of testimonials and case studies about, you know, its power to impact medicine and to make improved decision-making and operations and so forth. And there was a lot of that. But undergirding all of the conversation this year was a very, I think, healthy skepticism and also conversation about, okay, how do we regulate this technology? How do we govern it? Because there is a potential for significant harm and unintended consequences. There's a realization that's happening right now that there's no such thing as an off-the-shelf model. You know, there are all these companies that are out there, electronic health record vendors and others, that are selling models for imaging, you know, for use and decision support within electronic health records, and the performance of those models, as referenced in, you know, sort of the model documentation and the advertising and everything, does not apply to its use on the ground in individual organizations, such that there needs to be tuning, evaluation, you know, real understanding of how that's going to affect your own patient population. And so there was a lot of focus on that. I even attended one session where it was sort of framed as, if we don't address this urgently, we are in danger of another AI winter, you know, which is a period that happened in the 1960s in 1980s after initial sort of the coining of the term artificial intelligence and initial iterations of machine learning, where there was the technology in use failed to meet expectations. There was a disillusionment period and then a rapid disinvestment. And if this goes off the rails in healthcare, then we could see that again. The question is, so should it be industry doing that governance? Should it be government? What kind of conversations did you hear on the digital track?
I guess the most direct, speaker to address this issue is John Halamka, the president of Mayo Clinic Platform. And he basically spoke at length about exactly what you've described. My favorite anecdote that he had, or not anecdote, but example is, if we have a data set of 100 million Scandinavian Lutherans and we've created this amazing EKG algorithm, and then you decide to use it in Spain, we don't know if it's going to work. And the algorithms are only good as the underlying training data, but we don't publish anything to describe how these algorithms were developed or where it's meant to be used. And his opinion essentially is that we need an industry, private academic consortium, which you've written about, Casey, to come up with some of these standards and have sort of a nutrition label for these algorithms. And he spoke to the FDA's role in regulating, as they should, the safety of these algorithms as implemented. But he really thought that the role of sort of arbiter of these standards needed to fall somewhere else.
A couple of questions were coming in as you were speaking there that I wanted to try to get to. Let's see, Carol McCall, an attendee, asked, what regulations do you expect to see around healthcare AI? It's an interesting, broad question and topic to address. I expect to see a lot more focus on this. I mean, both the Government Accountability Office and the FDA have issued sort of high-level frameworks for regulation of artificial intelligence, sort of software as a medical device in medicine. So I expect to see some more, detail put into those, and I expect that we're going to see some, as John Halamka referenced and Katie referenced, some industry organizations perhaps forming and coming together, to talk about certification of AI algorithms, perhaps national testing laboratories, which would sort of begin to shape up like the Joint Commission, which most of us in healthcare know about. And the Joint Commission has really become an important organization and kind of a de facto stamp of approval relating to hospital quality. I think you could see the same type of thing beginning to emerge in machine learning and artificial intelligence, where you'd have, an industry group that would be vetting these algorithms before they go into care. So I think you'll start to see some news on that pop up in the next few months and weeks.
Yeah, I will say to some of the other questions that are popping up, I think we're talking here primarily about clinical decision support algorithms, but there were many other applications of artificial intelligence that were discussed at HIMSS. A lot of discussion of quote unquote hyper automation and how it's doing, relatively simple tasks that have never been automated in healthcare, from, getting your pharmacy stocked to sending in orders, and just the nuts and bolts of healthcare that are so often ignored. In these higher level conversations that we have about health technology. So that was a huge track that we have not devoted as much attention to in this conversation at this year's HIMSS.
Yeah, I mean, there is a ton of focus right now, and I'd say the predominant focus in especially healthcare providers is using artificial intelligence and machine learning for operational purposes. Some of those the algorithms that can support coding and billing, and and then as it pertains to patient care and sort of care management, readmissions risk algorithms, no-show algorithms to predict when patients might not show up for their appointments, scheduling of operating rooms, understanding bed capacity, equipment capacity, how that might change dynamically, relating to, demands on the health system and so forth. And I think you're going to see that sort of AI ramp up faster, because the implications of it are less, could be less severe for patient care. I mean, it's less likely to have a direct impact, direct physical harm on patients. So I think it'll be interesting to watch how fast that investment happens, how quickly that technology ramps up as compared to clinical decision support.
Yeah, another interesting thing related to that is, the degree to which artificial intelligence applied to some of the problems you just described are solutions to problems of our own making. We have an enormously complex healthcare system. It doesn't necessarily have to be so, but that's sort of the low-hanging fruit of artificial intelligence applications to, get through all of this unnecessary bureaucracy that we've built into the system. And in one panel that I went to, there was just sort of a call to action to make sure that we're still paying attention to upending the system and trying to rebuild a simpler and more value-based one, as opposed to continuously using technology, spending more money on technology to chip away at these, complex problems that we have created and built into the system. That is obviously a tall order, but so you get to be a little bit high-minded at these big conferences that happen just once a year.
Yeah, it'll be interesting to see, what the agenda looks like when HIMSS comes around in March again, which is actually not that far away.
Not just once a year, yes.
Yes. So, HIMSS right now is beginning to prepare for HIMSS22, which is scheduled to happen as usual in March in Orlando. So, looking forward to that, and seeing, over the next weeks and months how the conversation, that started and is continuing, evolves. And, I'll be doing a lot of reporting continuing on machine learning and regulation. So stay tuned for that. And I sadly have to say that I think we are at time. And so we have to sign off now, but I want to say thanks again to Katie for joining me today, Premier for sponsoring this event, and to our audience out there for tuning in. I'm sorry we didn't get to all of your questions. We did try to address as many as we could along the way. And again, we'll be hosting Stat Plus Conversation on Tuesdays each week. So be sure to sign up for our next chat, which is going to be on August 24th, when my colleague Alex Hogan will be sitting down with Elizabeth Stewart of Johns Hopkins School of Public Health. And they'll be having a conversation on children under 12, COVID-19, and vaccines as return to school is approaching. A note there that just for next week, that conversation will take place from 2:15 p.m. Eastern to 3 p.m. Eastern. It will be an interesting discussion, and we do hope you join us. Thanks again, everyone, for being here. Really enjoyed it, and we'll see you